Hi there, my valued, highly treasured and esteemed viewers and listeners, and welcome back to your channel of choice. My name is Dr. Nath Arwa, and I am a clinical pharmacist by training and by profession. I am the founder of Progressive Pharmacotherapy Consultants, a premier virtual clinical pharmacy institute for capacity building for healthcare workers. The Virtual Clinical Pharmacy Institute with a difference, where patient safety, medication therapy management, and optimal clinical outcomes are very crucial and non-negotiable to us. Here, we seek to remain your premier source of crucial tips for high-impact pharmacotherapy services, so I humbly urge you to sit back and spare me part of your very precious time to share some tips with you which you may find useful in your line of duty. So welcome to part 54 of our pharmacotherapy MCQ series, which majors in urology. The first question reads, basing on pharmacodynamic principles, which of the medications listed below makes the least sense to prescribe and administer to a 79-year-old male patient taking donepezil at a dose of 10 milligrams orally once daily? Would it be topical estrogen, oxybutynin tablets, pilocarpine eye drops, or raloxifene? I'll give you 10 seconds to choose the correct answer. Oxybutynin tablets is the correct answer. Now I'd like to emphasize that donepezil, which is marketed as Aricept, is thought to act by increasing the availability of acetylcholine in the central nervous system. And patients taking other medications that are centrally active anticholinergics, such as oxybutynin, marketed as ditropan, may counteract some of donepezil's effects, so I would opt not to co-administer it with donepezil. Let's move to the next slide, please. And the question reads, Mr. RJT, a 74-year-old male with newly diagnosed BPH, presents to your clinic, and your urology team intends to start him on sildenafil to relieve his lower urinary tract symptoms, which are abbreviated as LUTs. My question to you is, which of the facts listed below would you consider seriously prior to initiating treatment using sildenafil? Would you determine if he is also taking Proscar, which is marketed, the generic name or the brand name for finasteride, or would you determine if he's also taking a type 5 phosphodiesterase inhibitor, or would you determine if he has underlying G6PD deficiency, or would you determine if he is allergic to sulfonamide containing medications? I'll give you 10 seconds to choose the correct answer. Personally, I would opt to determine if he's also taking a type 5 phosphodiesterase inhibitor. I would like to remind you that sildenafil, which is marketed as Rapaflo, is an alpha-1 blocker, which is indicated for the treatment of BPH, benign prostatic hyperplasia, and it should be used with caution in patients already taking type 5 phosphodiesterase inhibitors such as sildenafil, due to the risk of reduction in blood pressure that could lead to dizziness and even orthostasis in extreme cases. Now, while uroselective alpha-1 blockers are less likely to cause hypotension and orthostasis compared to medications such as doxazocin, when they are used concomitantly with other agents that will have the ability to also lower blood pressure, it can end up in reductions in BP that cause symptoms in such patients. Now, most of the type 5 phosphodiesterase inhibitors are substrates of the CYP3A4 enzyme system, which sildenafil is also a substrate of, and because of that it could result in competition for metabolism. Now, sildenafil, which is called rapaflo, is a uroselective agent, that is, it's selective for receptors most commonly found in the prostate and the bladder area versus the vasculature. It doesn't target the blood system, circulatory system, or the blood vessels, and it is therefore indicated for the treatment of BPH preferably. I would also like to add that sildenafil has also been used for ureterocalculi expulsion as an additional indication. That's just for your information. Let's move to the next slide, please. The question reads, which of the following isn't a contraindication for flibanserin, which is marketed as ADI, in a 31-year-old woman who is being treated for hypoactive sexual disorder? Is it hepatic impairment, renal impairment, alcohol use, or strong or moderate CYP3A4 inhibitor use? I'll give you 10 seconds to choose the correct answer. So it is renal impairment. Now, flibanserin, or ADI, is indicated for the treatment of premenopausal women with acquired generalized hypoactive sexual disorder. It should be taken once daily at bedtime, and it is contraindicated with alcohol, with strong or moderate CYP3A4 inhibitors, and in hepatic impairment due to increased risks of severe hypertension and syncope. Now, in patients with renal impairment, there was no significant increase in flibanserin concentrations in clinical studies, so that makes B the correct answer. Let's move to the next question, please. And it reads, your urologist prescribed sildenafil for a male patient with erectile dysfunction. Now, the patient informs the urologist that sildenafil helped his erectile dysfunction. He has, however, complained of increased sensitivity to light. He informs the urologist that he has, in his own words, problems telling blue objects from green. A case of color blindness here. So my question to you is, which of the phosphodiesterase inhibitors or inhibitor subtypes listed below is most likely the cause of this patient's visual complaints? Is it subtype 6, 5, 11, or 4? I'll give you 10 seconds to choose the correct answer. Phosphodiesterase type 6 it is. Now, phosphodiesterase type 6 is located in the photoreceptors of the retina, and inhibition of this enzyme can lead to an increased sensitivity to light. It can also cause blurry vision and even a loss of blue-green color discrimination. Now, sildenafil, and to a lesser extent vardenafil, partially inhibit phosphodiesterase type 6, as well as inhibiting the main target for erectile dysfunction, which is the type 5. Now, I would like to add that phosphodiesterase type 4 is located in smooth muscles and immune cells and has been a target for COPD drug development, since inhibiting phosphodiesterase type 4 is associated with bronchodilation. That's just a by the way for you. Now, phosphodiesterase 11, on the other hand, is located in skeletal muscles, and when inhibited can lead to muscle and back pain. Now, just like to emphasize that tadalafil, another phosphodiesterase type 5 inhibitor used for erectile dysfunction, partially inhibits phosphodiesterase 11, and this is responsible for the possible muscle and back pain seen in patients who use tadalafil for erectile dysfunction. So when your patients complain about that side effect, no, it is due to the blockade of phosphodiesterase 11. Let's move to the next slide, please. The next question reads, Mr. AJO, a male patient, presents to your urology clinic. Currently, he takes tadalafil once daily. During today's appointment, he is concerned about possible drug interactions with other medications he is taking. So my question to you is, which of the medications listed below interact with tadalafil? Is it omeprazole, erythromycin, theophylline, or montelukast? I'll give you 10 seconds to choose the correct answer. So erythromycin it is. Now tadalafil, marketed as Cialis, and all other phosphodiesterase 5 inhibitors such as Sildenafil, which is Viagra, and Vardenafil, which is Levitra, are metabolized through the CYP3A4 isoenzyme system. Now tadalafil should generally not be administered with strong inhibitors of CYP3A4, such as the protease inhibitors, the macrolides such as erythromycin, and even itraconazole, which is an azole antifungal. Now, while other medications are metabolized through the CYP450 isoenzyme system, only erythromycin amongst this list is a strong CYP3A4 inhibitor, and that makes erythromycin the best choice in this particular question. Let's move to the next question, please. And it reads, your urologist intends to initiate pharmacologic or medical management for urge incontinence in a patient RMM who is a 90-year-old female using a medication which possesses a low potential to cause delirium. So my question to you is, which of the medications listed below would you recommend the urologist prescribes for Madam RMM? Would it be oxybutynin, solifenacin, trospium, or fesoterodine? I'll give you 10 seconds to choose the correct answer. Trospium, which is marketed as Sanctura, would be the best choice. It is a quaternary ammonium compound which is hydrophilic in nature and therefore doesn't cross the blood-brain barrier. And this gives us an anticholinergic medication that is less likely to produce delirium in such a patient. It would be the best choice among all the four. Let's move to the next slide, please. It reads, Mr. HPB, 56-year-old male, has been diagnosed with decreased libido and your urologist is considering testosterone supplementation. My question to you is, which of the statements listed below is the most accurate with regard to testosterone supplementation? Is it intramuscular testosterone produces normal circadian patterns of testosterone serum levels? Or is it true that testosterone supplementation should be used cautiously in patients with benign prostatic hyperplasia? Or is it true that testosterone supplementation should be considered in a patient with a testosterone level of 550 nanograms per deciliter? Or is it oral testosterone preparations are associated with less hepatotoxicity as compared to transdermal preparations? I'll give you 10 seconds to choose the correct answer. So the most accurate statement is testosterone supplementation should be used cautiously in patients with benign prostatic hyperplasia or hypertrophy, Now, BPH and prostate cancer are conditions that are testosterone dependent and may worsen during testosterone supplementation. Remember that. Therefore, the use of testosterone supplementation in these conditions should at least be done cautiously and in some instances be avoided completely to avoid worsening of the situation. Now, the ideal testosterone supplement or supplementation would produce normal testosterone concentrations and provide normal circadian rhythm levels of testosterone and its metabolites. Now, of the available testosterone preparations, the transdermal gel and the non-scrotal transdermal patch are the ones that essentially meet these requirements. I would like to add that the IM or the intramuscular testosterone products produce normal testosterone concentrations, but they don't provide normal circadian rhythm concentrations. They produce what we call the supraphysiologic levels. So that makes them a wrong option. Now, testosterone supplementation isn't recommended in patients with normal testosterone levels, where normal is between 300 and 1100 nanograms per deciliter. So that makes answer C wrong as well. Now, I would like to add that oral testosterone is associated with a higher risk of hepatotoxicity as compared to other preparations, and therefore it wouldn't be preferred. And that makes answer D wrong as well. Let's move to the next question, and it reads, which of the statements below best describes the action of alprostadil? Is it a dopamine agonist which decreases the release of prolactin from the anterior pituitary? Is it a synthetic prostaglandin E1 which increases cyclic AMP? Is it a synthetic steroid analog of 17-ethinyl testosterone which induces a high androgen state? Or is it true that it inhibits phosphodiesterase type 5, leading to an increase in cyclic GMP? I'll give you 10 seconds to choose the correct answer. B is the correct answer. Alprostadil is a synthetic prostaglandin E1 analog which increases cyclic AMP, which, like cyclic GMP, decreases cytosolic calcium levels, and that leads to smooth muscle relaxation, which in turn increases penile blood flow, sustaining or causing erection. Now, answer D refers to sildenafil, vardenafil, and tadalafil, which are the phosphodiesterase type 5 inhibitors. These inhibitors normally break down phosphodiesterase 5, to be specific, usually breaks down cyclic GMP, and that leads to an increase in cytosolic calcium. It also causes smooth muscle contraction, decreasing penile blood flow, which ends up in a loss of erection. That makes answer D wrong. Then I would like to add that giving a phosphodiesterase 5 inhibitor minimizes the breakdown of cyclic GMP, which prolongs an erection. Now I would like to add that alternative A refers to bromocriptine and cabergoline, which are the dopamine agonists that can be used to treat hyperprolactinemia, and they do so by decreasing prolactin release from the anterior pituitary. Now, hyperprolactinemia is a hormonal cause of erectile dysfunction. Now, danazol, on the other hand, is a medication used to treat endometriosis, and it is the one referred to in alternative C. It is a synthetic steroid analog of 17-ethinyl testosterone. So the correct answer in this particular case is B. Let's move to the next question, please. And it reads, which of the following medications is approved for once daily use in the medical management of erectile dysfunction? Is it sildenafil, tadalafil, vardenafil, or avanafil? I'll give you 10 seconds to choose the correct answer. Tadalafil is the correct answer. Now, tadalafil, which is marketed as Cialis, is an oral phosphodiesterase type 5 inhibitor that is indicated for an OD regimen in the treatment of both erectile dysfunction and for the management of signs and symptoms of BPH. It is also indicated for PRN treatment of erectile dysfunction. Now, avanafil, which is marketed as Stendra, is an oral phosphodiesterase type 5 inhibitor that is indicated for PRN treatment of erectile dysfunction, not once daily. Sildenafil, which is marketed as Viagra, and vardenafil, which is marketed as Levitra, are also oral phosphodiesterase type 5 inhibitors that are indicated for PRN management of erectile dysfunction. So that leaves us with tadalafil as the only once daily regimen. Let's move to the next question, please. And the next question reads, which of the medications listed below, commonly used for urologic conditions, is pregnancy category X? Is it tamsulosin, finasteride, silodosin, or tolterodine? I'll give you 10 seconds to choose the correct answer. Finasteride it is. Now, finasteride, which is marketed as Prosca, and dutasteride, which is marketed as Avodat, are 5-alpha reductase inhibitors which produce changes in dihydrotestosterone levels. Now, this hormonal effect creates the pregnancy category X warning. So women who are pregnant or trying to conceive should avoid contact with these products because of the potential to absorb these medications through their skin that can have far-reaching consequences on the fetus. Let's move to the next question, please. And it reads, which of the medications listed below works by competitive inhibition of 5-alpha reductase and as a consequence reduces the conversion of testosterone to dihydrotestosterone? Is it darifenacin, which is marketed as Enalblex, or is it Avodat, marketed as dutasteride, or is it tamsulosin, Flomax, or is it alfuzosin, which is Urosatro? I'll give you 10 seconds to choose the correct answer. Avodat or dutasteride it is. Now, this particular drug is a 5-alpha reductase inhibitor used in the management or the medical management of benign prostatic hypertrophy. Now, alfuzosin, on the other hand, is an alpha-1 blocker which is used in the treatment of BPH, and tamsulosin is an alpha-1 blocker used in the treatment of BPH, while darifenacin, Enablex, is an anticholinergic agent indicated for the treatment of overactive bladder. That makes alternative B the correct answer. Let's move to the next question, please. And it reads, Mr. J or J, a male patient, presents to a urology clinic with decreased libido and erectile dysfunction. Your clinical team suspects he has low testosterone levels and order a testosterone level from your lab. Now, the lab results are as follows. The testosterone level is 183 nanograms per deciliter. It's way below the lower limit, and the urologist decides to start him on a topical testosterone gel. So my question to you is, which of the counseling points listed below would be the most appropriate for Mr. J O J? Would you advise him to apply the gel at bedtime? Is it true that complete absorption takes 30 to 60 minutes and he should avoid showering within this time? Is it true that transfer of the gel is possible via skin-to-skin contact and he should watch for transfer to other people? Or is it true that the gel can be applied on the shoulders, the upper arms, or the genitals? I'll give you 10 seconds to choose the correct answer. So, the transfer of the gel is possible via skin-to-skin contact. So, such a patient should watch for transfer to other people through physical contact. Now, topical testosterone gel should be applied in the morning, as the onset is about 30 minutes. Now, complete absorption takes at least 2 hours, and that varies from brand to brand. There is a brand that takes as long as 5 to 6 hours after application. Because of that, any activity that may wash off the gel is such as taking a shower or swimming should be avoided during this time. Now, the gel may be applied to the shoulder, the upper arms, but application to other areas such as the abdomen, the genitals should be avoided. According to the literature insert, I would also like to add that transfer of the gel is possible, so Mr. J or J should watch for potential transfer to other people, especially women and children. That makes answer C the correct answer. So, my highly esteemed viewers and listeners, that brings us to the end of this video, which is part 54 of our pharmacotherapy MCQ series. If this video benefited you in any way, please remember to give it a thumbs up and to like it and to share it widely with your peers. And if you haven't yet done so, I humbly urge you to subscribe to my YouTube channel. I would like to promise you that the best is yet to come. Thank you very much for viewing this video and for listening to me. I sincerely appreciate your partnership, your continued support, and your kind collaboration. I look forward to interacting with you all in part 55 of our Pharmacotherapy MCQ series. Thank you very much for always being there for me.